From Microbe TV, this is Infectious Disease Puscast, episode 87, recorded on Monday, August 18, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. Thanks for holding down the fort last week, Daniel.
Oh, well, you threw an article in, so you're sort of there, and you're there in spirit. So that was good.
It feels like fall. I think it's probably just an exception today, but it is so nice outside.
Yeah, what a change, right? From like
100-degree,
just hot to a little bit pleasant.
Yeah. Well, I was at I guess if it was 2 weeks ago, the World Transplant Congress meeting. So got to listen in on some talks, but also just enjoy being in California for a little bit, which is nice.
And where in California were you?
San Francisco.
Oh, I love San Francisco. Beautiful town. Great place.
Awesome. Okay. Well, everyone, welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, we're going to start with viral. Remember to listen to TWIV, both the deep dive and the clinical update. And I think I may have even covered this on the clinical update, because this is another one of these articles addressing a theme that I really find fascinating, right? I mean, a lot of people have been concerned about things that might impact dementia, right? A lot of connections with the herpes viridae and dementia. So here's an article potentially with the connection between having a heart attack, having a stroke, and shingles and the chickenpox virus. So we've got the article, Adjuvanted Recombinant Zoster Vaccine is effective against herpes zoster ophthalmicus, all right, and is associated with lower risk of acute myocardial infarction and stroke in adults aged 50 and more years, published in CID, right? So we start with this background. And this is things we know, right? So we do know that herpes zoster shingles and herpes zoster ophthalmicus, that's basically shingles in your eyeball, are actually associated with an increased risk of cardiovascular complications such as acute MI and stroke. Okay, so maybe not everyone knew that, but just pointing that out, we actually know this. So here, they looked at the association between getting that recombinant zoster vaccine and not only the risk of getting shingles in your eye, but also ending up hospitalized with an acute MI or hospitalized with a stroke. And again, looking at adults 50 years of age or older at Kaiser Permanente, Southern California. So they conduct this matched cohort analysis of these adults 50 and over who received 2 doses of the shingles vaccine, recombinant zoster vaccine, 4 weeks and then 6 months, right, as recommended apart. So you get first shot, and then 1 to 6 months later, you get that second shot. And then they're going to match them 1 to 4 to unvaccinated individuals, and they're going to match them with age, sex, race, ethnicity. Follow-up started at the index date and ended at receipt of the zoster vaccine, termination of membership, death, or they're going to hit this end date of 12/31/2022, whichever came first. And they found that among 102,766 2-dose zoster vaccinated and 411,064 unvaccinated adults, the hazard ratios for herpes ophthalmicus, we see a 73% reduction, hospitalized with an acute MI, a 28% reduction, and hospitalized with a stroke, 42% reduction, getting that 2-shot shingles vaccine. It's amazing, right?
Yeah. I always try to encourage, when I'm encouraging or like trying to pitch the shingles vaccine, about how it has these sort of added benefits. Doesn't always work, but sometimes maybe it helps.
I mean, maybe they need to market it differently. Like,
Yeah.
here's a vaccine that's going to reduce your risk of getting dementia by about half. It's going to reduce your chance of ending up in the hospital with a stroke by about half. It's going to reduce your risk of ending up in the hospital with a heart attack by, almost 30%. That's huge. Like, why would you not want this vaccine?
Yeah. Yeah. Well, I will take us into the bacterial section. Be sure to listen to This Week in Microbiology. I didn't put as many articles in today, but I did spend a little bit more time with this next one. So I think probably it has popped up on people's reading list, but this was published in JAMA. Dalbavancin for treatment of Staphylococcus aureus bacteremia, the DOTS. So dalbavancin as an option for treatment of Staph aureus bacteremia, that's where the DOTS comes from, randomized clinical trial. So asking the question, is Dalba a superior treatment option for complicated Staph aureus bacteremia compared to standard of care? So in this trial, they included 200 adults completing therapy for complicated Staph aureus bacteremia. And the probability of more desirable outcome at day 70 with Dalba versus standard therapy was 47.7%. So that did not achieve the pre-specified criteria for superiority. But we'll talk in a little bit more detail. So this was an open label, assessor-masked, randomized superiority trial conducted at 23 centers in the US and Canada, looking at hospitalized adults with, as I mentioned, complicated Staph aureus bacteremia. So these are adults who achieved blood culture clearance and resolution of fever after receiving at least 72 hours, but no more than 10 days of initial antibiotics. They used the 2011 IDSA guidelines for defining this sort of uncomplicated versus complicated. So just to remind everyone what the quote uncomplicated Staph aureus bacteremia, unicorn that's out there is excluding endocarditis, no implanted prostheses material, follow-up blood cultures 2 to 4 days after initial blood cultures do not grow staph, defervescence within 72 hours, no metastatic sites of infection, and more. But that's kind of the gist. So if they didn't make that, they can fall into complicated. They did exclude cases like those with CNS involvement, left-sided endocarditis or perivalvular abscess, prosthetic material, unless they knew it was going to come out. Same thing with prosthetic joints, only included if the removal is planned. They took out polymicrobial infections, significant hepatic insufficiency, severely immunocompromised, pregnant and breastfeeding patients, and a few others. But those are kind of the big ones. So they assigned patients 1-to-1 to receive dalbavancin 1,500 milligrams IV on days 1 and 8 from randomization versus 4 to 8 weeks of standard therapy. So cefazolin or an anti-staph penicillin for MSSA, or Vanc or Dapto for MRSA. And the primary outcome was this desirability of outcome ranking DOR, which I think we've, talked about a couple times, at day 70. So this includes 5 features. So clinical success, so survival with resolution of signs and symptoms. They look at infectious complications, safety, complications or issues, mortality, and health-related quality of life. And so I mentioned there were 200 patients total, 100 in the Dalba group and 100 in the standard. 167 patients, or 84%, survived to day 70 and had this efficacy assessment. The probability of a more desirable day 70 outcome with dalbavancin versus standard therapy was 47.7%. And we mentioned that sort of concludes that Dalba was not superior to standard therapy. If you look at their secondary outcome, you'll find that the standalone sort of clinical efficacy was documented as 73% for Dalba, 72% for standard therapy. So that does meet the non-inferiority margin. And then serious events, they logged as 40 in the Dalba group versus 34. It makes the numbers easy that they're all over 100. And so this, DOR endpoint is meant to give this more balanced measure of harms and benefits. trying to create a statistical endpoint that might align more with how we think and the reality that our clinical decisions and outcomes aren't binary. There are drawbacks to that, of course, too, but I think it gives a sense of patients who have more complications versus those who have less eventful courses. I think one thing that is noticeable is that the assessment survey that they used for quality of life didn't necessarily look at the features that we might think of as pluses for dalbavancin, like discharging home versus going to a facility, having a, not needing a line or having a line infection, comparing that to having to take daily medications. And really that question of discharge home versus facility wasn't really addressed, but I think something that we obviously think about, especially when we may be considering reaching for dalbavancin. But the overall takeaway is that dalba was really non-inferior to standard care in that sort of what you could call consolidation phase after they've cleared their cultures. And it was similar to standard care for all the components in the door outcome, but not superior. I actually am not totally sure I understand why they went for superiority instead of non-inferiority. But anyways, this provided us some, info on dalbavancin. I think it reinforces that it can be a good option when you need it. You may just have to kind of keep in mind who is excluded and who might not be the best candidates in some of those more difficult to treat scenarios. Thoughts, Daniel?
I feel like they may have missed some of the sort of the desirability outcome, because if you think, oh my gosh, look how simple this is. You get a shot of dalbavancin, 1,500 milligrams day 1, get another 1,500 milligrams on day 8. Like that's it. I shouldn't say a shot. So it's an intravenous, infusion. But then you're done. And they're comparing, some of these folks were on 8 weeks of IV therapy, right? And they've got a PICC line when you're going out to 8 weeks and all the complications that come with that. They're ending up, often in a SAR, right? So subacute rehab. Think of all the money involved in monitoring your Vanco, your Dapto with your CPKs and everything else. It just seems like maybe, as far as these hard outcomes, it was equivalent. But all these sort of bigger picture outcomes, costs, the rest. I mean, I think with some of sort of managing and a stewardship point, you might want to start saying, hey, why aren't we doing more of this, right?
Yeah, and the way it's reported makes it seem like it's not right. It wasn't superior, but it basically performed very similarly and patients did okay. And I feel like that's the takeaway is that you can use dalba, or at least that's how I am taking it away. So there's always these gymnastics of the wording and having to think through how to take it into your practice or consideration. But I think good news. I've tried to use dalba when I can, and hopefully we'll be able to use it more and more.
Yeah, what's the barrier that you're finding in your use of dalbavancin?
I mean, it's still making sure that the patients can get to the infusion center and that they will come, I think is, ignoring costs and some of those things. But if you can get it set up, I think sometimes even if they can come for an infusion, maybe it's hard, for transportation or something else to get them there. Yeah. But
all right. Well, moving on to the article, propensity matched comparison of timely versus delayed antibiotic therapy in Stenotrophomonas multifilia pneumonia, published in Open Forum Infectious Disease. Sort of thinking about that title, right? It's so we're comparing getting that treatment timely versus just sort of waiting around and. All right. So here we get the results of a retrospective cohort study. Which makes sense, right? Not going to really prospective. These people are going to treat them properly. These other people will wait a while. So we're kind of looking at when this happened and comparing, trying to see how much harm. And the study included adults hospitalized with Stenotrophomonas multifilia pneumonia at University of Kentucky Healthcare, 2014 to 2023. Patients received active monotherapy or combination therapy with TMP sulfa, minocycline, or levofloxacin. Timely therapy was defined as initiation within 48 hours, so less than or equal to 40 hours from index culture collection. Delayed therapy as greater than 48 hours. They've got 430 patients, 215 per group. They're doing that door analysis, that desirability of outcome ranking. And I don't know if you noticed, they've got this wonderful, what do they call it? Graphical abstract with a door.
Mm-hmm.
Okay. So they do that door analysis that everyone should be familiar with. And they showed a 72.8% probability that timely therapy resulted in patients being alive with fewer or no clinical events. Kaplan-Meier analysis confirmed higher survival with timely therapy, with a 22.8% absolute reduction in 30-day mortality. So you're looking at survival rates of 87.9% when you get it timely versus 65.1% with delayed. And a time-dependent Cox model adjusted for calendar year and COVID-19 time period confirmed timely therapy reduced death hazard by about 50%. So we've got an adjusted hazard ratio of 0.48. So just if you were thinking it doesn't really matter, yeah, it's nice to get that therapy started in a timely manner. Don't wait 2+ days.
I have to say, the only thing I don't like, well, I'm not very picky about a lot of things, but I don't really like it when graphical abstracts use like the skull and crossbones for patient death. That's the only thing I don't know. It's like the one icon that I feel like there's got to be a different option / we don't, I guess, have to put an image, but it does make it symmetrical.
What do you want for the deceased? What
I don't know. Well, I know now that I said I don't like it, I have to think of a pitch, but I don't know. It's something about it I've never.
Like maybe we'll do a tombstone or something.
Yeah, I know. Well, it's always some like kind of cartoony thing, and it always feels a little wrong. But that means I need to think of an alternative. I'll have to like sketch out something that we can use instead.
All right.
This next one I pulled from OFID quite quick. I kind of just pulled the tagline of it, but basically the paper I'll start off is the proportion of treponema pallidum PCR positive primary syphilis infections which are seronegative for syphilis, a systematic review and meta-analysis. And so the authors here in this review identified 8 studies of a lot more. I forget the number. But basically they found 758 individuals with syphilis PCR positive primary lesions that had serology performed at the same initial visit. And among these, they found a pooled estimate of 10% were negative on all serologic markers, with a range of 4 to 20%. So basically, 1 in every 10 cases detected by PCR would have been missed by serology alone for this primary syphilis. So just pointing to how this could be helpful in detection of primary syphilis. And I don't think I had a number in mind of what that would be. So if you guys are thinking about it, it's about 10%. I'm not sure that I necessarily have sent PCR recent. I'm trying to think if I had. I was probably also just it hasn't come up in my clinic in a while, but.
Yeah, I thought this was interesting. I mean, a couple things. Yeah, as you point out, how often have I ever actually sent off a PCR from a Schenker, testing?
Yeah.
I sort of assume, like, I actually was assuming a higher rate of negative serology, right? Because that's the whole idea. Like, it's a primary lesion. Maybe, sort of the dynamic here of when were you getting that serology, right? Because if they come in with an acute lesion, it's been there for a few days. I was sort of expecting a higher percentage of folks with a negative serology. And then, you go ahead and treat based upon, clinical story and the Schenker and risk factors and all the rest. So, yeah, sort of interesting. All right, the article, Cefixime versus benzathine penicillin G for the treatment of early syphilis, a randomized control open label trial published in the Journal of Antimicrobial Chemotherapy. Kind of relevant, right? Because we're having a lot of benzathine penicillin G shortages, right? So
we really paired we didn't intentionally do this. Two-door articles, two syphilis.
I'm taking credit.
Okay.
Yeah, no, I thought this was I was like, oh, this will go right well with that. Yeah. Maybe. Who knows? We'll see. So we've got this RCT, randomized controlled trial, 61 patients. I would like some more, but they've got confirmed early syphilis, randomized to treatment with Cefixime 400 milligrams orally twice a day for 14 consecutive days, 2 weeks, or to a single shot of the benzathine penicillin, that big intramuscular shot that everyone loves. 95.1% completed the study, 28 patients in the Cefixime arm, 30 in the benzathine penicillin arm. In the intention to treat analysis, the primary endpoint, a 4-fold or more decrease in venereal disease research lab tests, so that's greater than 2 dilution steps, from baseline to 3 months, right? So that's a primary outcome. And maybe I'll have some comments on the primary versus second. So primary outcome was achieved after 3 months in 73% of the patients that get Cefixime and 87% of the folks that get the penicillin injection. But then they check at 12 months. This is their secondary outcome. Now you've got 93% in the Cefixime, the oral, and you've got 96.8% in the benzathine penicillin arm. They say both treatments are well tolerated, no serious adverse events or adverse events with severe intensity reported. But I was sort of curious about the 2 endpoints, right? Like what exactly was going on here? Like when they didn't have this drop at 3 months, they said, well, that's okay. We're in a study. Let's wait till 12 months. Like, any thoughts?
Oh, I see what you're saying.
Right? Like they just sort of at 3 months says, you're not quite there, but I'm just going to keep my hands out. Like, wouldn't that have prompted you to like jump in, right? And treat them, say, listen, quarter of you people have not had that serology drop. I feel like I've got it. So really interesting that they just sort of sat on them for that extra 9 months before rechecking.
Yeah. I wonder, as you were going through, I was like, oh, would I prefer having 14 days of an oral antibiotic or 1 shot and to be done? I mean,
what were you thinking?
I don't know. I mean,
it's a big shot, right? I mean,
I
that
know,
shot is
I know.
big. It hurts.
Yeah, but
I mean, so I hear. I mean,
yeah.
Never personally actually gotten that big shot, but
Yeah. Well, I'm realizing we didn't pull any fungal articles this week.
And
I think I meant to go back.
I looked again today. There was one on like the epidemiology of different fungal infections in transplant. And I was like, well, but I don't know. I sort of felt like if it wasn't really worth our listeners' time, I was like, sorry, nothing. We're skipping the fungal section. Go watch some reruns of The Last of Us.
Well, we have some things for parasitic. Please be sure to listen to This Week in Parasitism. Anything you guys got coming up that you're excited about, Daniel?
We had to do a solo recently. We're not really solo, a duo thing. We're just Vincent and I were doing it because Christina was probably off at some conference or something. And that was going through this, really cool. I guess I like when pathogens impact like your brain, right? And maybe this is like The Last of Us. And it was all about how the supposedly dormant cyst stage of toxoplasmosis is actually impacting neural function in mammals and creating this excitotoxic state. So really, fascinating stuff. So
well, I'll kick us off. So in OFID, I pulled the paper Increasing Length of Babesia Season in New England in the Climate Change Era. This was a retrospective cohort of about 1,100 patients with babesiosis over 30 years, and it showed expansion of the babesia season over time with an increase of about 0.33 months per year. So I actually pulled figure 1 and figure 2, so you can see the linear trend in figure 1, and figure 2 is like a calendar heat map, basically. So the linear model, you can see just shooting up as we head closer to 2020, corresponding to an annual growth in cases of about 14%. And then you can see the expansion of the probability of cases in figure 2, and sort of as it moves along, spanning more months of the year. obviously still concentrated around, July or June through August, I guess I should say, but stretching way, way into the other parts of the year. So I always, I like talking about babesia. So it led me to pull this, but I also pulled it because on a separate and also different tick related note, there was an article in New York Times this past week talking specifically about the uptick. Pausing for the
You got that uptick.
Did I pause long enough? Of alpha-gal syndrome and folks on Martha's Vineyard who are basically going vegan because there's been a pretty significant Lone Star tick population, and they have these like dramatic pictures of some of the general stores on Martha's Vineyard having vegan items. But it is really interesting and sounds, alpha-gal does sound quite miserable. The red meat I could get over, but if you had it to the point where you can't really have dairy, I'd be quite sad. But anywho, So if people can have two, popular press and a regular tick article for today.
All right. I Martha's Vineyard has a special place in my heart. When I was a teenager, I worked out there at a Camp Jabberwocky, which is a camp for kids with cerebral palsy, spina bifida, Down syndrome. But yes, the Alice in Wonderland, 'twas brillig and the slithy toves did gyre and gimble in the waves. So it had that whole theme. And
Great.
All right. So I've got the article. Actually, people were writing in asking questions. So how could I not discuss the article? Ivermectin to control malaria, a cluster randomized trial published in the England Journal of Medicine. In this study, they conducted a cluster randomized trial in Kwale, a county in coastal Kenya, in which malaria is highly endemic and coverage and use of insecticide-treated nets are high. Clusters of household areas were randomly assigned in a 1-to-1 ratio to receive mass administration of ivermectin or albendazole once a month for 3 consecutive months at the beginning of the short rains season. Children 5 to 15 years of age were tested for malaria infection monthly for 6 months after the first round of treatment. The 2 primary outcomes were the cumulative incidence of malaria infection assessed among children 5 to 15 years of age and of adverse events. A total of 84 clusters comprising 28,932 eligible participants underwent randomization. The baseline characteristics of the participants were similar in the trial groups. 6 months after the first round of treatment, the incidence of malaria infection was 2.2 per child year at risk in the ivermectin group and 2.66 per child year at risk in the albendazole group. So basically seeing about a 26% reduction, good p-value there, 0.02. Really no issues with adverse events. So they did find that among children 5 to 15 years of age living in an area with high coverage use of bednets, ivermectin administered once a month for 3 consecutive months, 26% lower incidence of malaria infection than albendazole. And they've got some nice graphics, some nice figures in there where you can see that separation. But I was left with a couple questions. And so here are the thoughts. So are we using ivermectin to target the malaria parasites or the mosquitoes? So the results do stem from a protocol that was approved by the WHO Vector Control Advisory Group. So maybe that's a hint on what people are thinking. This trial also showed a community-wide benefit with ivermectin, right? So not just helping the people who are getting bit by the mosquitoes. So, there might be 2 things going on. So ivermectin can have a role in killing the mosquitoes that spread malaria. But there's also evidence that ivermectin is an effective anti-parasitic targeting several stages of the malaria parasite's life cycle. So we might actually be getting a 2-for-1 here.
It's very cool. I saw this one. I don't think I realized which week it was. I think I pinned it and forgot to go back, but very neat.
Yeah, no, I think it was a little bit, and then so many questions about it. I was like, all right, okay.
I'm glad you brought it in.
Yeah, ivermectin, what is it good for? So, all right. So in our miscellaneous, I'm going to talk about vaccines, so flu shots, right? We're coming up. It's August, before you know it, it's going to be time to get that flu shot. If you're 65 or older, which flu shot to get. So what does the CDC currently tell us? Who knows what they'll say in a month or two, right? But currently, the recommendation for adults 65 or older is to preferentially receive any one of the following, we'll call them like senior flu shots, the high-dose inactivated influenza vaccines. So that's the HDIIV3 or the Fluzone high dose, is high dose there. Just really inactivated flu vaccine, it's just a higher dose. Or you can get a recombinant influenza vaccine, so that's the RIV3, the flu block, or you can get an adjuvanted inactivated flu vaccine. So that's like Fluad and the AIIV3. Is that AII or A2, or how am I supposed to do that?
Are they Roman numerals?
Are they Roman numerals? I don't know. I got to look that up. And then here's like the caveat. Say, but if none of these are available, then just get whatever. So I'm sort of like, wait a second.
Regular dose flu shots better than no flu shot.
I guess that's true. But yeah, it seems like we should make sure there's adequate supplies. Like they're going ahead and making a recommendation. People are going to be kind of like, walking away like, So here's a question. Does it really matter? So we've got the article, Relative Effectiveness of High Dose versus Standard Dose Influenza Vaccine against hospitalization and mortality, according to Frailty Score, a post hoc analysis of the DanFlu-1 randomized trial published in JID, Journal of Infectious Disease. So I like this because we're not just looking at antibodies, right? We're actually looking at hard outcomes, ending up in the hospital or dying, right? That skull and crossbones, that we're not going to use anymore. So these are the results of a post hoc analysis of the randomized feasibility trial of the HD. Have we decided how we're going to pronounce that? Is it IIB or?
We can stick with I until someone tells us the Roman numerals.
So we're looking at the high dose versus the standard dose conducted during the 2021-2022 flu season. In older adults aged 65 to 79, they assessed pre-specified outcomes, including hospitalizations and mortality. They break the vaccines into those having the vaccinees actually, into those having high versus low frailty scores, trying to decide if that's going to really make a difference. And so what is this frailty score thing? So there's this hospital frailty score. And really you look at ICD-10 codes for comorbidities, right? So do you have some other associated illnesses that might increase your risk? So you can do that like a electronic medical record review, things like that. So among 12,477 included participants, mean age 71.7, about half of them are female. We've got most of them, so 85.7% were low frailty, and then we've got 14.3% had high frailty. And then we're going to break down and going to look. So they're going to look at the high dose recommended for those over 65 versus the standard dose associated with a lower risk of first and recurrent hospitalization for pneumonia and influenza, regardless of the frailty. And then we're going to see this low frailty hazard ratio of 0.37, and we're going to see high frailty hazard ratio of 0.33. So really across the board, it didn't really matter whether you were frail or less frail. The high dose flu shot was associated with a lower risk of first and recurrent hospitalizations for pneumonia and influenza compared with the standard dose.
We were overthinking it. It is inactivated influenza vaccine, II.
So it's II.
I know. I feel like I usually just say high dose.
Yeah. Standard versus high. So basically what we're seeing is we're going to reduce mortality, right? So the mortality was down. It's about 74% reduction in mortality. Pretty significant, reduction, 60, 70% reduction in ending up in the hospital. So it actually looks like the high dose is really the way to go over the standard dose. So shop around, find out where you can get one of these recommended flu shots if you're 65 and over.
Love it. Get your flu shot. Okay. And that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher or on YouTube, where you can subscribe, you can like us, you can ring the bell, you can leave nice comments, please. We love to get your questions, comments, and paper suggestions, so send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or go to Parasites Without Borders. Click on parasiteswithoutborders.com.
I'm Sara Dong. You can find me on Blue Sky at sarawindong.febrilepodcast.com or just at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puzzcast is infectious.